So it is my really great pleasure to introduce Dr. Sara de Valle, one of my favorite scientists and role models in the field. I don't remember when I first met Dr. de Valle, but I have been following her work and comparing notes for years and years. We were both researchers in the earlier days of the Midas Network. Sara is, or Dr. de Valle is a scientist and project leader in the Defense Systems and Analysis Division of Los Alamos National Labs. And please, add any details that I don't have in front of me when you introduce yourself. She received her bachelor's and master's degrees from the New Jersey Institute of Technology, her PhD from University of Iowa. She does a lot of the kind of things we do. She builds models, but really on just an unprecedented scale to address all sorts of interesting questions about the spread and control of infectious diseases, including smallpox, anthrax, malaria, HIV, influenza, and of course, COVID. And we're going to hear about some of her work on COVID. She's focused particularly on understanding the role of social behavior on disease dynamics, including the impact of social media. And again, really develops really innovative types of computational approaches. Her team also submits forecasts to the CDC Forecasting Hub. They've done some really interesting forecasting in New Mexico. And I think you're going to talk today about some vaccine prioritization work, but if not, that's another area they've been working on. And I'll say one of my favorite moments. I love New Mexico, and I've spent a lot of time in Santa Fe at Santa Fe Institute, visited Los Alamos a few times. But a few years back, I took my kids to, I don't know what the real name of it is, but we always just call it the Bomb Museum in Los Alamos. And I was there and I'm looking at the displays and there's a picture of Dr. de Valle and a quote from her on the wall. And I was like, I know her. And my kids were so excited. So she's a legend in Los Alamos and a legend, in the world of disease modeling. And we're really just so pleased to have you here today. So please take it away.
Thanks, Lauren. You're so kind. Everything you said about being a role model is, I send it right back to you. You've also an amazing scientist, and we follow your work, and we're happy to take any of your students anytime. So just putting it out there. And we're super happy with Lauren Castro. She will be now converted into a staff scientist. So that's pretty amazing. And I feel like you've been training a lot of students, and I think the world is better because of that. So I'm going to try to share my screen now. Okay, let's see. Okay, so can you see my slides? Okay, great. So as Lauren said, I am going to be talking today about some of our COVID-19 modeling work. We have been working on a lot of different aspects of COVID, as probably many other groups are, forecasting and also projections. But today I'm going to talk about some of the vaccine distribution strategies we're doing using an agent-based simulation. And so I wanted to start with like a short clip about some of our work here at Los Alamos. This is from National Geographic. They featured our work a few years ago, and I feel like they really, just like everything that National Geographic does, they really captured what we do in a very succinct way. And so this is just a 1-minute clip of their show, the big picture with Kyle Penn. And so I just wanted to show you just to kind of see what we do here at Los Alamos, and specifically what my group or my team is doing.
Infectious diseases are a national security issue.
Sara del Valle is part of the first line of defense.
Can you turn a little bit louder? All right, do I need to turn louder?
Can you hear better?
At airports, Chicago, Atlanta.
At Los Alamos, they run what-if computer simulations that predict how far and fast the fallout from a biological weapon might spread and how many people might die.
We need to figure out how to quickly distribute vaccines and treatment. After the anthrax release in 2001, there was a concern that other diseases could potentially be spread, and so that's why we started developing these systems that could allow us to understand what-if scenarios.
What-if scenarios can be terrifying and ominous.
Oh, I'm sorry if you couldn't hear the audio very well. I don't.
It was fine. I would just turn up my volume. I could hear it. It's great.
Okay, great. Yeah, so we have been preparing for pandemics for, a long time, and it is unfortunate that the day came when we actually had to use some of these models to respond to a pandemic. But thankfully, I think that the community, a lot of the scientific community was ready to use their models and provide decision support for many of the questions that came our way. And so this is basically, this has been our goal. And so I just wanted to put it out there that, we want to improve decision support by monitoring, forecasting, and projecting diseases. And as a mathematician and with a very highly interdisciplinary team, we are using different data streams and different types of models to quantifying uncertainty. And maybe you've heard about this approach from other modeling communities, but basically this is what we've been trying to do, is we've been trying to borrow a lot of the expertise from the weather forecasting community and applying them to infectious diseases. And so basically the way I understand that weather forecasting works is they take observations from many different sensors, have satellites, they have ground sensors, and they combine them with physics-based models to provide forecasts for hurricanes and for weather, for snowstorms. And so we're using a very similar approach, and we're trying to exploit a lot of data from mobility data, transportation data, even satellite imagery to understand mosquito populations. And then we're combining them with mathematical and computational and statistical models to provide probabilistic forecasts with quantified uncertainty. And so basically we're trying to combine the data-driven and model-driven approaches. And we feel that the 1 + 1 = 3, because, the combination of these kind of approaches can provide us with a more robust solution. And so I wanted to first give you the definition of forecast and projections. Today I'm going to be talking about projections, but since sometimes people use the two interchangeably, I wanted to make sure that you know what I'm going to be talking about today. So basically, forecasts attempt to predict what will happen based on current trends. And we are doing that. We are providing forecasts for COVID as part of the forecasting hub. But today I'm going to be focusing on some of the projection modeling that we're doing. And so basically here we're trying to we are attempting to describe what would happen given certain hypotheses or what if scenarios. And so that's basically a lot of the work that I'm going to be presenting is in what if scenarios. And so because I'm going to be showing you the results from an agent-based simulation, probably many of you are already familiar with agent-based simulations. But I just wanted to give you a brief kind of introduction about simulation and where simulation sits in the community. And so I really like this quote from former US Secretary of Energy, Stephen Chu, that said, previously scientists had two pillars of understanding, theory and experiment, but now there's a third pillar, which is simulation. And simulation basically takes theory and experiment to develop these simulations. And so also just going with a little bit of the history about agent-based models, interestingly, agent-based simulations or the concept about agent-based modeling was developed here at Los Alamos in the 1940s by Ulam and von Neumann. And the first models that they proposed were very simplistic, and basically you provide a specific rules to your agent. So in this case, they had, they started with a block cell, and then as time goes by, then you allow this square to basically expand, and so these small rules actually then give, and you will see the emerging dynamics of the rules that you provide to your agents. And so then you can, now we use a lot more sophisticated rules and more sophisticated environments to understand infectious diseases, but the same concept applies. And I think agent-based simulations became a lot more widespread and used in the 1990s when, because of the computational requirements. And so that's one of the limitations, I guess, of agent-based simulations, is that we have to use our supercomputers to run them just because they're computationally very expensive. And so, as many of you are probably familiar, there's, we have a lot of different tools in the EPI community to solve, different problems and questions. And so we have system of differential equations, and we also have, agent-based simulations. We also have statistical approaches. And so I wanted to just give you a few examples on why you would use an agent-based model. So basically, if your system is too complex to be captured by analytical expressions or experiments, some of the things that we're doing is, trying to understand the impact of restaurant closures or restrictions. And so because we have to account for all the restaurants in the US or in New Mexico or in DC, then that level of resolution is more likely to require an agent-based simulation. You can obviously do this with a system of differential equations with an SIR type model, but then you would end up with like hundreds of equations. And so that could be not very efficient. Also, we have heterogeneous compliance by county, by age, by gender. And so putting all this kind of information in an ODE type model would be more difficult. And so using a simulation, you're able to have more flexibility and do a lot of different things. Also, the vaccine distribution, which is what I'm going to be talking about today, now it's being open to everyone. But at the beginning, only healthcare workers and first responders and senior citizens could get vaccinated. And so that's why we're using this simulation. And also, if experiments are too expensive or undesirable, assessing the impact of different vaccination distribution strategies, it would be too expensive to just try different things. And so doing it in a simulated environment is always a good option. Okay, so I'm going to be talking about one of our many different agent-based simulations. So I'm going to be talking about Epicurves, and this is a model for the US. And basically, we have 2,000 person communities in over 65,000 census tracts in the US. And the model has, geography and demographics. We have age, household composition, household size by county, that is basically statistically identical to the census. We also capture different contexts in different settings, from work, household, school, or within the community, or at the supermarket. And because of all this detail, we're able to capture and assess the impact of different mitigation strategies. I think one of the unique features of our model when you compare it to other models is the ability to stratify the workforce by industry classification. And so basically, each worker in our simulation has a job, and so we're able to differentiate a nurse from a teacher, from a truck driver. And so because we know all the healthcare workers and all the first responders in our simulation, then we're able to prioritize them when it comes to vaccination. And then we can see what the impact of those prioritizations are. And as I mentioned before, agent-based models are very computationally expensive, and they're data hungry. And so we use a lot of different data streams to parameterize our model, from census data, transportation, mobility data. A lot of different data streams are being used to help us figure out what the parameters should be. Because I'm going to be talking about vaccine, I wanted to kind of give you, there's a lot of assumptions, and I'm going to just give you a brief overview of some of the more important assumptions. But if you want to know more about other assumptions that I'm not mentioning, just let me know. So in terms of vaccine, we are assuming that people are 50% get 50% protection after the first dose, and then 90% protection after the second dose. We are giving those the second dose 4 weeks apart, and I know that the Pfizer vaccine, for example, you get it 3 weeks apart. The Johnson & Johnson, you're only going to get 1 shot. But in order to simplify our model, we decided to just kind of use basically the worst case scenario, which is the Moderna vaccine. And so this is what we're using for our simulation. And we're just assuming we have 1 vaccine, and we're not really modeling the impact of different vaccines. We started with a 10 million vaccines per week assumption. I think the US is doing better. So maybe our simulations are going to be a little bit pessimistic. So that's something to consider, and that's a limitation. We are using the ACIP prioritization recommendations. So we have healthcare workers getting vaccinated first, essential workers, seniors, and then after the percentages of people that we assume that will be willing to get vaccinated from these populations, then we start vaccinating the rest of the population in our simulation. We explored 2 different scenarios. One is with 60% compliance, and the other one is with 80% compliance, and we are assuming the 16 plus. And so basically all the children won't get vaccinated. And we did the simulations towards the end of January or beginning of February. So we assume our initial conditions were mid-January, and our model usually takes a week of data or 2 weeks of data to calibrate the model. So we try to match the trends at the county level. And then once we are able to match the trends, then we can project forward. And so just a few more assumptions about schools or some of the scenarios. We simulated different scenarios. And so because we are rolling out the vaccine in the simulation, we also wanted to account for the school situation. And so we explored different schooling options. So we have 100% attendance, 5 days a week. We have 80% attendance, 5 days a week. And the reason for using the 80% attendance is because apparently there's been surveys, and at least 20% of the parents might not be sending their children back to school because they could be immunocompromised or they have some other issues, and so they don't want their children to be going back to school in person. We also have the hybrid scenario where basically we split the 80% student population into 2 cohorts. Each cohort of 40% goes to school 2 days a week, and then we have the virtual learning or the closing all the schools. We explored different reopening scenarios. So what happens if we reopen in February or March or April or May? And then also for the summer, we said, what happens if you extend the school until June, for example, and so you can start summer in July, or you can start the summer in June. And as I mentioned, we're using a lot of mobility data to help us with social distancing assessments and parameterization. This has been one of the hardest pieces for us to learn and to get data for. Social distancing compliance is very heterogeneous across the country, but we don't really have a very good and reliable way to capture face mask compliance and also just mobility and social distancing compliance in general. And so we have been relying on the unicast scores to help us with that. And so there's obviously limitations because you can't really, you're not really looking at everyone and seeing if they're wearing a face mask or not. So we are assuming that face masks and social distancing will continue, through our simulated period. And we are assuming that there's going to be a reduction in contacts as a result of these interventions. And we're assuming 75% for phase 2, and I will explain what phase 2 means, but basically it's a more restrictive phase, and then 50% reduction for phase 3. We also have a lot of different assumptions about teleworking and that kind of stuff. And so now I just briefly to talk about what I mean by phase 2 and phase 3. Basically, phase 2 means fewer workplaces open. So basically you have more restrictions in your community. And then phase 3 means you have more workplaces open and limited restrictions in your community. And so I know that the current administration is not using this terminology of phases, but I think it's just, if you think about lifting up restrictions, that would be like phase 3. And if you have a more restrictive or closed community in terms of businesses, then that would be phase 2. Okay, so I think that took care of all the assumptions and the model. And so now I'm gonna show you some of the results. And this was like an early, some early results in that when we first started simulating the spread of COVID. And so as you can see, we started in April. And here at the beginning, we were trying to just assess, what would happen if the current stay-at-home policies are lifted on June 1st of 2020. And so I just wanted to kind of show you this movie that kind of shows what would have happened if that happened. As we know now that, the stay-at-home orders, remain for just about a whole year. So, so these simulations, in some areas they weren't lifted, but in some areas they were lifted. Okay, so now starting with the vaccine, with our current set of simulations, and this is using the vaccine distribution that I just mentioned before. And here we have, I'm just showing you the 60% vaccine acceptance, and I wanted to compare what happens between the phase 2 and a phase 3, given the current 10 million doses per week. And so you can see the baseline is this black. Let me see if I can use my cursor. I guess I can't really use it, but it's the big black curve. And so that's the baseline. That's no mitigations. Everything is open. Schools are open. But then we have a yellow epidemic curve starting on February. Then we have another one, March, April, and May, and that is based on the assumption that we're going to reopen schools. So basically, there are several lines that are at the bottom, and those are for the hybrid and closed scenarios. So basically, the virtual learning and the hybrid school, which is splitting the school population into 2 cohorts, and each cohort going to school 2 days a week, gives you almost identical epidemic curves and almost identical outcomes. But when you reopen the schools at the current vaccine rate, you can see the emergence of secondary waves of infection. And so, however, delaying the school, if you reopen in May, you can see that although you do have a slight increase in number of cases starting in May, the number of cases is not as bad as it was if you had reopened in February or March, for example. And so this is...
Sorry, Sarah, can I just ask you, remind me, I can't remember from the introduction, but do you assume that if you open in May, schools then shut down again for summer in June?
Yeah, so
Okay.
I don't know if you see some lines that are, and I don't know why I can't really use my cursor, but basically there are some lines that are coming down starting in June, and there are other ones that are coming down starting in July. And so basically that's, if you shut the schools in June, then you can kind of see a pretty drastic drop in number of cases. And the same thing happens in July. So you see a decline in the number of cases, and then they all kind of converge towards that yellow curve. And so although the dynamics look pretty similar for phase 2 and phase 3, I wanted you to pay attention to the y-axis because it's different. So basically for phase 2, you have 800,000 cases. Obviously that was for a baseline scenario with, no interventions. And then for phase 3, you have 1.2 million daily symptomatic cases. This is for the whole US. And I will start drilling into different states later. But this is kind of the overall picture. And so there's some take-home messages at the bottom. Okay, so here also I just wanted to show you the the clinical attack rate, or the percentage of people who will become symptomatic for all the different scenarios, including the baseline. And this is for all the states. And you can kind of see, you can see Texas, for example, here for, this is phase 2, phase 3. I mean, yeah, phase 2, phase 3 on the left, and then phase 2, phase 3 on the right. And then I have 60% vaccine acceptance and 80% vaccine acceptance. And so the differences seem small, but I will drill into the specific differences later. But one caveat that I forgot to mention at the beginning is that we are not accounting for variants right now. So this is like under just the wild types circulating in the population, and we're vaccinating people. We are starting with a chunk of the population already exposed to COVID-19, and so all of these things play a role. If we were to account for variants, I think we would probably see a different picture. And so here, this is for New Mexico, and I wanted you to see because it was kind of hard to see the differences in the 60% and the 80% in the previous slide, just because there were, I had too many states and too many numbers, and so it was hard to see. But here we have the cases averted for this 60% and for the 80%. And so basically you can see that you will be able to avert more cases if you vaccinate a larger proportion of the population. And obviously this is consistent with what we know, and we would expect that the more people that get vaccinated, the better outcomes you will have, and the more people you're going to be able to avert in terms of getting symptoms or getting hospitalized or dying. And so here I wanted to also show Texas, just since you guys are in Texas. Wanted to show you some of the spatial differentiation between phase 2 and phase 3. And here I'm showing the scenario where you have 80% school attendance. So 80% of the kids start going to school, and I'm forgetting starting when. So it could be starting maybe in February. So I apologize, but I can let you know which scenario it is. And so you can clearly see spatial differentiation across the different counties, and you probably have better understanding of what which those counties are. And from what we've seen in other counties that we're more familiar with, it seems like the spatial differentiation is driven by local demographics and initial conditions. So basically, because we have certain types of workers in each of the counties. So workers where a lot of the businesses or the workers are not able to telecommute, for example, or work from home. Those are the counties that will probably have higher impacts, just because people have to go out and work, and counties that have people that are able to work from home more seem to have less impacts. And so here also I just wanted to show you some of the Epicurves for Texas. Here also we have 60% acceptance, and then we have the phase 2 and the phase 3. And so you can see here I removed the baseline, since that one seems to be too unrealistic given the current conditions. But basically we have that, if you reopen in March or April or May, and then you can kind of see the number of cases declining when the schools close for summer break. And so clearly, I mean, obviously the same take-home message about phase 2 seems to lead to better outcomes than phase 3, and that's just due to the business activity assumptions that we put in the model. So I mentioned that one of the unique features of our work is the ability to capture industry impacts. And so here I wanted to show you just some of the industries that we wanted to keep track of, and this is for New Mexico. And so you see that for some scenarios, we still have the healthcare staff, with higher number of employees getting sick. And the reason for that is because we're still assuming that only 60% of the healthcare workers or 80% of the healthcare workers will accept vaccines. So we're not assuming that just because you're a healthcare worker, everyone will get vaccinated. We're still applying those 60 or 80% assumptions that we used for the entire population. And we believe that that is actually consistent with some of the data that we've seen come from healthcare workers. And so the other thing that I just wanted to point out is that, education services or school staff also seems to have, just a slightly higher number of workers potentially sick. For some of the scenarios, you also have workers at grocery stores also have, in some scenarios, have a higher probability or higher risk of getting infected. However, if you look at the y-axis, I mean, the numbers are pretty small, and we've been doing this for several months now, and I think that this is actually really positive, that the vaccine is actually making a difference in terms of the number of people that could be exposed and potentially develop symptoms. So I think in conclusion, limited business activity, or phase 2, which is what we're calling it, obviously reduces the number of cases. So because we're not able to vaccinate everyone at once, I think we need to keep some of the restrictions that we've been having for a while still implemented in the communities if we want to have a greater impact of the vaccine. The hybrid learning scenario seems to provide the most balanced approach in terms of enabling in-person education and increasing impact. As you may remember, hybrid learning and closed or virtual learning basically give you identical results. Reopening the schools with a 10 million dose per week assumption is likely to lead to secondary waves of infection. However, depending on when you reopen, that the impact can go up or down. Also, just to highlight again that a lot of the spatial differentiation seems to be driven by the local demographics and compliance and initial conditions. And then some industries such as healthcare workers, retail, and school staff seem to be at higher risk for some scenarios, but still it's a lot lower than what we were seeing before. And so I just wanted to give a shout out to the team. Obviously, I'm here presenting our work, but this was in collaboration with Tim, Lori, Mandy, Jeff, Morgan, Carrie, and Terry. I don't have a picture. And so I think that's all I have.